That is of the rural, not of the rural, but non-urban areas, where the era was when I have to carry with my scope, my instrument, my monitors, everything. Nowadays, in the rural also, you have like very good like monitor, scope, IITV, everything. In that era, with the 6-inch high frequency, we have to start the work, identify. Even though patients were happy, but complications are there. See, nothing is without complication into open or endoscopy. The complication ratio remains even same or minimal, but it remains. Recurrence, infection, neural injuries are always there. But why the acceptance is higher? Because of the ultra minimal invasiveness, because of the so many other things that comes in the picture. This is prevalence. Nowadays everybody knows that it's a very high prevalence. And now it's not about that it is for like low socioeconomic. Now it's related with the all from lower to affluent. The challenges that I said, these are the challenges when I started. Now it's going to be equal as if you are in urban or rural. But that was the past. So adopting this endoscopic spine surgery, why it was easy. Initially, I started everything under local anesthesia. That was the first generation. Before 10 years, it was the first generation, then second generation, then third generation. Today, we all are talking about fourth generation. With monoportal, with biportal. Everything is endoscopic fusion. So this is fourth generation. So see, everything is remains same. Though I wrote cost is low, but it's equal. The data collection, data analysis and outcome, as I said. So almost we can say recovery ratio is faster, daily activity they can start early. This is what a demographic used. Almost mean age was 52 because almost all are laborer, heavy work. Male is higher than female ratio. Indications majority are lumbar disc congestion, then spinal stenosis. Even posterior, sometimes I used to do hybrid. If it is posterior higher, more than even moderate to severe for a pleural hypertrophy, I used to do under local decompression, and then hybrid means transfemoral go and sometimes, because see, under local if you retract the nerve root or dural sleeve, it is very painful. Patient will not allow you unless you do spinal or epidural. But I never use spinal in the rural. Even sensory epidural and local, that helps, that serves the purpose for the monoportal or biportal also today. So this is what surgical outcome and complication, as I said. Pain reduction very fast because you have targeted. Functional improvement, they can join earlier, they can even mobilize within the same day, they can go for their daily activity, they can resume their work and earn very fast. And complication ratio, though it's there, lower, but it's there, as I said. It's infection, bleeding, nerve damage, right? And infection, even though we say that we are irrigating, but somehow infection ratio is there, even into the transforaminal or even monoportal or UB, infection ratio is there. And you can directly dock on the disease fragment. You are directly over the nerve root. You are directly seeing the dura. So complication to the neural injuries, unless you are blind or even you cannot see. See, don't proceed. This is the dictum. Bones are your kind of very good friend. Always trace the bones in the endoscopic spine surgery. It's not a blind surgery. If you cannot see, stop it. If you can see, then only proceed. Your anatomy, fluoroanatomy, endoscopic anatomy, everything should be clear, thorough. Then you can perform at any place. It's not about high place, low place, any place. You can perform any damn procedure with the UB, with monoportal or transforaminal. Important is your indication. Your indication matters. For all indication, it's not single surgery. For transforaminal, it can cover 50% of the indication. Monoportal will again cover 80% of the. UB almost it covers 99.9% indication. So patient satisfaction, as I said, because of the early mobility, improved quality of life, reduction of the pain, and return to the work, that reduces the cost. Barrier to the widespread acceptance of the endoscopic spine surgery because of the awareness, because of, see, sometimes one complication goes to the prominent surgeon and they say, it's okay, cannot be done with the endoscopy and that can be only done with the fixation fusion. But if there is no instability, you can try with all these answers. I'll show you one image. See, conclusion is continue research, training, and policy support. Please, last image is there. Now see this image and criticize me. The patient, young, with hepatic failure, with anticoagulant, with low ejection fraction. What I did, I don't want to say. The date itself will say what happened to him. The 28th-9 pre-op with left EHL EDL weakness grade 3/5. 29 immediate post-op. Almost patient was walking after procedure. Discharge, went home, and after 14th day, he came again with severe, with the same pain, with the same and higher. See, if I didn't go for intermediate MRI, what my another option opinion consultant would suggest to patient? See, I'm not criticizing our practice, just I'm telling about. See, forget about in between image. The same patient, forget about in between image. Now tell me, what my second opinion surgeon would advise to him? There is nothing has been done. There is no scar, no mark, nothing has been done. Then what? See, it's a clear image. The same sagittal, same place, same herniation. Two were the same MRI, third was of Surat. And the comparison. Now, for the revision. Now tell me, again, shall I go for the endoscopy or fixation fusion? Audience poll. Almost 90% says fixation fusion with all this. I must say, again, I'm go for fragmentectomy under local and same thing. Now, what else I'm going for? Recurrence disc herniation. Yes, sir. Done. Thank you.